Well, you've come back and you're very welcome. Thank you for tuning in again. Bit of a more global update today. We'll be looking at some quite alarming news, I think it has to be said, from Spain. Things developing in the US, talks of vaccines, and things going on in the UK. And then we'll see how we get on after that for time. So that's roughly the plan for today. Now, congratulations to everyone in Thailand. They've had 100 days without a single confirmed case of local transmission. Now, this is really quite incredible. If you can compare this to certain other countries you could mention, maybe the one you live in, for example, or the one I live in, for example, it really is quite impressive. So 100 days without a locally transmitted case. Now, there's still severe travel restrictions in Thailand, and they're suffering terribly from the lack of tourists and other effects of the pandemic. But to get local transmission basically gone is very, very impressive. Now, the next one I want to talk about, the next place to talk about is I want to talk about Spain. Now, let me just load a graph here for Spain just to give you a bit of background. Now, we see that the number of cases in Spain here reported is higher than the number of the cases in March at the start of the lockdown. Over 8,000 cases being reported a day, and that line looks like it's only going in one direction, doesn't it? It looks like it's going up. Now, having said that, the cases were probably higher at the start of the lockdown because there wasn't as much testing as there is now. But there's still dramatic increases in cases in Spain. There's no question about that. But thankfully, it's not reflected in deaths. And we're going to look at this in a bit more detail today. But this is the deaths here, and I've put this on the logarithmic scale. In other words, 1, 10, 100, 1,000. Just so we can see the detail, because the numbers are actually relatively low. So we see it's about 30 deaths a day. Low for what we would expect. Well, compared to the height of the pandemic, I mean, the deaths were what? What were they there? There were over 700 a day. So great increasing cases, but not so much increases in deaths, very much not increases in deaths. There will be a bit of a lag effect. We know about these lag effects. We've talked about them many times, but that's not enough to explain the magnitude of the difference we're seeing. And it will be mentioning why the death rate is so low. I mean, it's good news. The death rate is very low. We'll give a few hypotheses for that shortly. But this is the bit that I found, I was a bit taken aback when I read this actually. Now, Madrid is the epicenter in Spain at the moment. Most cases are in Madrid, or there's a lot of spread in Madrid. And this is the president of Madrid. And she has said this. Most returning school children likely to contract COVID-19. In other words, basically, looks like she's given up. She says, oh, all these kids are going to get it. The kids are going back to school. They're all going to get it. Okay, the children could all get it. They'll have very low levels of morbidity and mortality, but they won't be zero. Some children will get sick, and if there's a lot of children, there's a risk of death in children. It's not no risk, but of course they're going to take it back and spread it around to everyone else. So this seems to be an admission that the cases in Spain, or in Madrid anyway, are going to just carry on rising, and there seems to be a bit of a resignation to that. Now, she does say that necessary steps have been taken to make sure schools are very safe places. Bit of a contradiction there, clearly. I think what she's trying to say is that she's in charge of schools. Therefore, she's made those safe, but kids are going to get infected outside of schools. So it's not my fault. I mean, I don't know. I might be being completely unfair. But she's saying she's made schools safe, but the kids are going to get infected outside of school. That's what she's saying. But most of them are going to get infected in the next few months. Not a very impressive performance from what I can see. Over the course of the school year, it's likely that practically all the kids will get it one way or another. And when it's in italics here, this is direct quotes. Practically all the kids will get it one way or another. Probably not through her schools, because they're very safe places. She's seen to that by being a competent politician. But they're probably going to get it in other places. That'll probably be because they pick it up over the weekend, at a family gathering, or in the park in the afternoon, or from a classmate. So they're not going to get it in her nice safe schools, but they're all going to get it anyway. The fact that they're going back to school appears to be a coincidence. We just don't know because the virus can be anywhere. So basically what she seems to be saying here is most of the children in Madrid are going to get infected with COVID-19 over the next few months. Oh, but it's not my fault. Anyway, I don't really care about the fault thing. The point is that we can assume that the president of Madrid is well informed by her epidemiologists, and basically she's saying that everyone, all the children, are going to get it, and the implications for spread of that, of course, are huge. So, somewhat bemusing, but not inconsistent with that graph that we saw for the increasing cases in Spain. Now, let's move on to the United States. We'll start off with the tracker here. So this is live data from the United States. Well over 6 million cases, 184,000 deaths, and nearly 300,000 cases in the last 7 days. And of course, with this being a live tracker, you can hover over your state, or do you have to click? I'm not sure. Doesn't seem to want to play. Maybe you have to click. And it'll tell you all about the detailed information wherever you live. So there we see the figures in the United States. Increase cases and a lot of cases in the last 7 days. But having said that, when we actually look at the graph for the increase in cases in the United States, the rate is not accelerating. So here we have the graph for the United States. These are the number of new cases. This is official data. This is from Our World in Data. We know there's big question marks over it, but it's all we've got. Well, it's probably the best we've got. So we see the number of new daily cases are going down from a peak of 66,000 down to 43,000 new cases per day. But that's still a lot of new cases per day, of course. So problem by no means over. Deaths in the United States haven't fallen anything like as much as the reduction in deaths that we saw in Europe, in Spain, for example. So the United States down from well over 2,500 deaths at the peak, down to still, well, that's the 1,000 line there, so under 1,000 with this 7-day rolling average, but still quite a lot of deaths in the States. And of course, it's always good to know how the hospital system is coping. Now, this is the hospitalizations in the States. Now, this is the older age group, over 65, younger age group, and these are the children here. So what we see is that the number of hospitalizations, these are the weekly hospitalizations, I think, weekly rate, are well down. So the highest weekly rate of hospitalizations was here back in April, fell off nicely, then there was a bit of a peak again, July. Now it's down again and looking hopeful. So reduced numbers of hospitalizations in the States, indicating that less people are getting very sick, but the number is always increasing, well over 6 million people now infected. So let's look at what the CDC is saying at the moment. Health officials notified to expect a vaccine for health workers and high-risk groups early November. So this is like about 8 weeks away. So they're saying that there's probably going to be a vaccine starting to be rolled out in 8 weeks' time in the United States. Interesting. Very interesting indeed, and it has to be said, impressive. The officials in the states have been, in 50 states and quite a few cities, have been told to prepare distribution networks and preparation. And the vaccines involved are going to be vaccine A and vaccine B, which of course is intriguing. They're not saying what vaccine it is. Now, coincidentally, if you saw yesterday's update on this channel, this is exactly what we talked about. So let's look at what we talked about yesterday. We mentioned the Oxford University AstraZeneca vaccine. Now, I think we can eliminate that one. I don't think it's going to be that one. So what it's likely to be the Moderna vaccine that we looked at in detail yesterday and how it works and everything. I'll put a link up for that video if you want to see it. So going to the Moderna vaccine or the Pfizer BioNTech US-German collaboration vaccine. And we know that the United States has already put in 1.5 billion for pre-orders on the Moderna, and 1.9 billion for pre-orders on the Pfizer BioNTech vaccine. So almost certainly going to be one of those. I can't see it can be anything else really. So there we have it. That's impressive. Now, who's saying what about this? Now, I did suspect something like this might be happening because there's been kind of rumblings. So there was rumblings from Dr. Fauci, and Dr. Stephen Hahn is head of the FDA, Food and Drug Administration. And they were talking about a vaccine may be available for certain groups before clinical trials have been completed, if the data is overwhelmingly positive. Now, is this reminiscent of the situation in China and the situation in Russia, where they've started using the vaccine before the phase 3 clinical trials have been even started, let alone finished? And the answer is no, emphatically not. What happens is when a trial is going on, it will report to a review body. Now, let's say this is a new drug. So there's a new drug that's being tried against, say, a placebo or against an older drug. Now, suppose that new drug is killing lots and lots of people. Then you can't wait for a year or 6 months till the trial finishes to realise that. You've got to review it as you go along. And if you find out the death rates are much higher in the new drug group than in the placebo group, the trial will be cancelled. Or other times, and this has happened quite a few times, you find out that the new drug is so efficacious. So the new drug might be saving 90% of lives, whereas people in the placebo group, 90% of those are dying. So, huge difference. So you might get lots of people dying in the placebo group, lots of people surviving and getting better in the drug group. In that case, it would become unethical to carry on giving a placebo because the data is already in for the statisticians to calculate that the result is significant or highly significant or very highly significant. Therefore, it would become unethical to carry on giving people the placebo. And this, of course, is what is happening in these two trials. This is happening in the in the Pfizer phase 3 trial. It's in the Oxford-Zeneca one as well, which was not going through the one in the States, and in the Moderna trial. So all of these vaccines, people are getting a placebo at the moment to compare it with. Now, if it comes in that the vaccine is definitely efficacious, then it would become unethical to carry on giving people the placebo. So what these two reputable doctors are saying, these two doctors here, Dr. Fauci and Dr. Hahn, what they are saying is that if the data is overwhelmingly positive, then the vaccine could be rolled out earlier. And in fact, it was very reasonable to argue that carrying on giving people a placebo when you know you have a highly efficacious, highly safe vaccine would be unethical. So I assume this is what has happened here. So this is nothing like the situation in China or the Soviet Union where they just skipped that bit. Nothing like that at all. Basically, you see something that's obvious is easy to prove. I mean, let's just take a ludicrous example. If you throw 10 people off a 1,000-foot cliff and they all die, then it's reasonable to assume just from a sample of 10 that that's going to kill you. So a sample of 10 there could be enough, and you could say, well, no, that's enough. We need to stop this trial now. It's unethical to throw people off cliffs because we know that 100% of them die. That's ludicrous, but I think you get the idea. Whereas a trial I took part in years and years ago, with the International Study of Infarct Survival, we were working out whether people do better if they're given aspirin after a heart attack, and that's a much more subtle effect. So you need much bigger numbers to be able to work that out. So, we know there's 30,000 people taking part in this vaccine. If 10,000 have already been infected in the placebo group and none have been infected in the vaccine group, again, the figures are there. They're statistically significant. That is enough data to say case proved. So I think that's probably what's happening here. And if it is, this is remarkably good news. Remarkably good news. So yeah, so that vaccine should be rolled out in early November, starting with high-risk health workers and high-risk groups, and then going on to other people after that. So in other words, what it means is by the 1st of January 2021, quite a lot of people in the United States could be vaccinated and therefore immune, greatly increasing herd immunity, greatly reducing transmission of this virus. We could see a really rapid drop-off in cases in early 2021 in the United States, because this vaccine does seem to be working. Otherwise, they wouldn't be rolling it out early. So that means that COVID-19 could cease to be a problem in the United States by probably about next summer. This is impressive. If this is working, it's impressive. We don't know yet, of course. We have to wait and see, but that's what it sounds like is happening, and that is certainly consistent with the normal protocols for new drug evaluation in phase 3 clinical trials. Now, that doesn't mean to say that the data will no longer be collected after that. As soon as people start getting vaccinated, then they'll carry on collecting data. So in essence, the phase 3 clinical trial will carry on. It's actually a phase 4. It's the post-release data collection, which will go on indefinitely for the whole life of the vaccine, collecting more and more data, but it looks like the efficacy is demonstrated. So that is, I mean, the import of that news for the United States is incredible. And of course, that will be rolling out to other places as well. And I'm also, from everything I know so far, expecting the Oxford AstraZeneca vaccine to be as effective. I'm expecting it to be as effective. That's based on information that's published from phase 2 clinical trials, but I don't have the data from the phase 3 clinical trials. No one's rang me up to give me intermediate results, so I don't know. But I'm expecting that to be hopeful. So I am pretty hopeful. What I'm less hopeful about is the speed at which this vaccine will be rolled out to poorer countries. I hope it's fast, because there's still a lot of people getting sick and dying in India, in Brazil, other places like that. So websites for you to click on there: overall cases, hospital cases, and hospital rates. Always posted in the what do you call it? The bit below the video, the description. Now, Nancy Pelosi. Don't know much about her. Famous or quite senior American politician, I believe, has regularly told American citizens to wear masks and follow the guidelines. And of course, she hasn't herself. Seen in a hair salon without a face covering. Okay, not great, but specifically it's breaking the city's COVID-19 prevention rules. Now, of course, rules aren't for important people like politicians. Rules are for the hoi polloi like you and me. They can just go on and do what they want. Right, just 2 words for Nancy Pelosi. Don't really know you, ma'am. Don't really know what you do. Don't know much about your politics. But my 2 words are unacceptable. These rules are for everyone. Do as I do, not do as I say. Enough said. Right, now, high cases, low death rates. We've been looking at this for some time now. Cases seem to be rising, but the death rates are low in most places. Now, having said that, in the United States, the death rates are still quite high compared to Europe. But the death rates are dropping. The case fatality rates are getting less than we thought they were just a few weeks ago. The infection fatality rates, and we looked at this in detail a few days ago, under 0.5% in most cases, or around about that. For the whole population demographic. So why are cases low? Let's just take Spain for an example. Let's just remind ourselves actually of that those graphs in Spain are so impressive. So they're the increasing cases, and of course all the school kids now, we've been told, in Madrid are going to get it. Don't know how many school kids there are in Madrid. Tens and tens of thousands, I would have thought. That's going to just go soaring up the way, according to that. According to the authorities in Madrid. But the death rates, just remind ourselves, despite the high cases, relatively low. So that's good. So why is this, is the question. Now, I'm not going to be able to give you a definitive answer, but I've got a few ideas on this. Younger demographic, of course. So a lot of the spread this summer has been younger people having a good time, as you would expect, in summertime, socialising. So yes, that's a factor. Viral mutation. Has the virus mutated to a less virulent form? Probably not. Better management of cases? Absolutely. We know more about managing cases now. Now, it's a very sensitive test, vulnerable to contamination. So one possibility here is false positives. Because this test, if there's like only one sample of the virus there, it can multiply and multiply and multiply it. So there are possibilities of false positives and contamination from some labs, giving an impression that the numbers are actually higher than they are. Don't think that's a major problem. Most labs are absolutely meticulous about this, but it is a possibility. Older cases clearing harmless viral fragments. Now, this is certainly a factor, I think. Now, I'm going to give you a paper on this in a minute, but we did look at this a while ago because it was data from Korea was showing that quite a high proportion of people were getting reinfected with the virus weeks or months after they'd had the virus, but they weren't getting reinfected. It was just residue of the virus that was still being cleared by the respiratory system. And the test is so sensitive it was detecting fragments of the virus which weren't capable of reproducing. The people were not infectious. Of all those people where they detected fragments of the virus and they came up positive on the PCR test, remember from the Korean data, not one of them spread the disease. They weren't infectious. But it's an aspect of this PCR test, the way it multiplies up the RNA of the virus, being so sensitive that it gave the impression that people were being reinfected when they weren't. Having said that, we now know that people can be reinfected, but it's very, very, very few. Very, very few indeed get reinfected. Now, just one paper that demonstrates that briefly, because I know you get a bit bored with papers, but this paper here, read it for yourself if you are interested. Some COVID-19 cases test positive again for the SARS coronavirus 2 RNA following negative tests after they've been discharged. But tests have shown that these people do have neutralizing antibodies, so they've had the antibodies. So what this study is showing, and it's consistent with the previous data we looked at a couple of months, probably about 6 weeks ago now, maybe a month ago, from South Korea, that shows that people are not getting reinfected, but they're still clearing residues of the virus. In other words, people were admitted to hospital or tested positive, had the illness, developed antibodies, got better, retested for the antigen, tested positive again. They weren't reinfected, they didn't still have the active infection, they were just clearing residues of the virus from their system. It's an artifact of the sensitivity of the test. So that, I think, explains why quite a lot of people might be testing positive who've actually recovered from the disease. So that's one possibility. But if you put all those things together, like younger demographic, viral mutation, better management, a very sensitive test, clearing all fragments of the virus, I still don't think it answers the question. So the main answer, I think, is what we looked at a couple of days ago, the reduced inoculum. In other words, people are getting infected with lower doses of the virus. So the idea here is that if you take precautions like wearing masks, like social distancing, yes, you can still catch the virus, but you'll be infected with a very much smaller number of viral particles. Therefore, you're much more likely to be asymptomatic and have mild disease, and much less likely to die. So if this is true, and I believe it is, it means that the precautions that you are taking to reduce spread is going to reduce the viral load that you could be exposed to if you're going to be infected, and that could save your life. Do watch that video again, the one on reduced inoculum dose. Lower doses of the virus causing less severe disease. Having said that, we don't have double-blind, randomised, controlled trial data on that. It's based on observational data, but it's based on good observational data, and I think it's true. Now, masks and viral load, therefore. So wearing a mask is going to reduce the viral load that you are infected with, therefore making it more likely you have a mild illness or an asymptomatic illness. Now, a couple emails on that came in after this video from Michael. Everyone in Thailand was wearing a mask back in February. The army was on the streets giving them out. What did they know then that we only know now? Good question. The Thais had this all worked out in February. If you live in the United Kingdom or the United States, we did not have it all worked out. People need to be held accountable for this. We've been let down by senior health officials, in my view. Now, I'm no politician fan, as you know, but I'm not blaming the politicians for this one. The politicians were closely advised by their medical advisors and their scientific advisors. I feel they're the ones that let the politicians down and through them let us down. Because this data was known about, as Michael simply points out there. Likewise, Andrew. Here we are in September, fully 6 months after Taiwan made mask wearing a social responsibility. They based the decision on the very same evidence we've known for more than 30 years. Confirmatory evidence for the reduction in spread in the reduction in the deaths has been available in Taiwan since March, 6 months ago. And you might remember that we interviewed Craig from Taiwan on this channel in great detail about this, and he confirmed this data from first-hand experience in Taiwan. The Taiwanese situation is an empirical experiment with a sample size of 23 million. Good sample size. Good point, Andrew. 23 million. And makes these recent earnest efforts seem a bit superfluous. If you need a control group to check the alternative, no mask thesis, pick the UK. So yeah, compare Taiwan with the UK, and there you have your experiment. Now, moving on to the UK itself. Now, cases have been up a little bit in the past week. And the Office for National Statistics, as we know, the ONS, Office for National Statistics, always a little bit behind. And there has been a slight increase in cases in the past week. Not dramatic, nothing like Spain or France, but a slight increase. But let's look at the figures that we know. This is the week ending the 20th of August, where we have full data. Click on the links. Very nicely presented information. So in this week, England had 28,200 people had coronavirus. That equates to 0.05 of the population, been the same since the start of August. 1 in 1,900 people. They give the same information in lots of different ways, so it's quite good. That's 0.4 new infections per 100,000 per day. That's 2,000 new cases per day. The COVID symptom tracker app at the moment says it's 1,947 new cases per day. Now remember, this data here is 2 weeks behind. And the ONS data always gives higher numbers than the COVID symptom tracker data, because that includes asymptomatic people that were tested. So that means that the actual ONS data for today is probably going to be about 2,500. Of course, we won't know that for another 2 weeks, but I would guess it is because we need to add a bit onto what the COVID symptom tracker app says. And if you actually look at the history for the past month or two, the past month, probably the past 6 weeks, the degree of agreement between the COVID symptom tracker app and the Office for National Statistics is absolutely impressive. It's almost spot on now. So Tim Spector and his group have really got their act together on this COVID symptom tracker app. 4 million people filling it in now. I'm one of them. Please start filling it in if you're not already. Just Google COVID symptom tracker app, stick it on your phone, and report in every day. It takes about 1 minute. COVID symptom tracker app is reporting 22,000 active cases now. So unfortunately, in a week or two's time, the Office for National Statistics data relating to now the beginning of September will show higher cases because there has been a slight increase reflected in official data and reflected by the COVID symptom tracker app, consistent sources of data. Always good when these different sources of data agree with each other, and right now they are. So this is reliable data. Wales, smaller population of course, 1,100 people in Wales had COVID-19 in that same week. That's 1 in 2,800 people, slightly lower. Now the UK Office for National Statistics in terms of deaths, 57,300 deaths involving COVID-19 have been registered up to the 20th of August on death certificates. Quite a bit higher than those that have been tested and then died within 28 days of testing, which is the current criteria as collected by Public Health England. Clearly the Office for National Statistics data is more reliable because many people have died from COVID-19 who have not been officially tested. So this is on clinical grounds on death certificates. And doctors do take filling out death certificates pretty seriously. So I think this is fairly valid data. So the actual number of people that have died in the UK, the United Kingdom as a whole, from COVID-19 is 57,300 up to the 20th of August. Thankfully, since August to now early September, there haven't been too many cases, too many deaths. But of course, that number will only be growing. Thankfully, growing quite slowly. So that's the total number for the UK. England and Wales, England and Wales 52,000, Scotland 4,222, Northern Ireland 871. I haven't added it up. You can do it if you want, but assume that plus that plus that equals that. If not, we'll check with the Office for National Statistics, but I assume they can add up. Roughly what you'd expect. England, of course, much greater population than Scotland, greater population than Northern Ireland. Now, household restrictions and gatherings. You might remember that there was a whole swathe of area in North England, about 4 million people. North Manchester, parts of Yorkshire, parts of Lancashire, where they stopped home visiting because that was identified as a driver of transmission. Now, in my mind, this was very good epidemiology. They'd identified a specific area and a specific type of behaviour. So they said in this specific geographical area, this specific type of behaviour is now mandated against. You're not allowed to do that. So quite a smart lockdown there. Quite an impressive piece of epidemiology. I agree with it fully. There's quite a lot of whinging about it at the time, but it's based on good science as I understand it. And these have now been lifted in most areas, apart from subsets within that area, and the areas that it hasn't been lifted are Bolton and Trafford areas. So again, this is even more localised lockdown. So most parts of Manchester, Yorkshire and Lancashire now, the restriction is lifted. But in Bolton, weekly incidence now is 66.6 per 100,000. It was 18.9, so it's increased. It's gone from that up to that. Therefore, the restriction needs to carry on. And again, it's the household visiting that have been identified as the driver of transmission. 17.8 per 100,000 in August, now up to 36. So we see the increase there. Again, quite good, precise, regionalised epidemiology. So happy with that. It's the way to limit infection with the minimum inconvenience to the minimum number of people. Right. Now, I did have a scientific study to do here, but I think I'll probably leave that till tomorrow now. I'll give you the bottom line of it. Steroids save lives in critically ill people. That's the bottom line of the study I was going to give you. But I'm not going to do it now. We don't want it for too long. Tell you what I'll do. Now, I I actually lied to you a few weeks ago. I said everything on the shelf behind me has been carefully chosen for allegorical and academic or something of other significance. Now, that was a lie. I did admit that was a lie. It's just bric-a-brac that I didn't bother tidying away when I tidied the shelf. But we talked about the YouTube thing, we talked about the black dog thing. So today, this is completely irrelevant. The video's finished now. This is purely trivia. I'm going to show you my Phrenology Globe. And here it is. Now, where can we get a good view of the phrenology? Let's get it on the overhead. I'll show you it on here first. It's this thing here, right? Now, you've probably seen these around. Phrenology by L.N. Fowler. Now, these are just a historical curiosity, really, but what they are is, and you will have seen them around, but these Phrenology Globes. So let's, how's the light there? Can we get some, yeah. So these Phrenology Globes, what they do is they show various attributes of a personality related to different parts of the head. So here, for example, acquisitiveness, acquires, saving, hoarding. So that's like the acquiring bit of the skull, that's like the saving bit of the skull, and that's like the hoarding bit of the skull. Or if we go back a bit, what's that bit there? Secretiveness. So reserve, policy, evasion. Okay. So these are all, anyway, these are all personality characteristics. And what L.N. Fowler did back in Victorian times, look at that bit there, reasoning, causality, planning, that sounds good. Criticism, comparison. These are all things that people are good at, and personality traits. And what you do is you feel someone's skull, and by feeling the contours of the skull, that tells you whether they're good at this particular activity or not. So all you got to do is learn all these bits of the skull, then you can assess someone's personality completely just by feeling the skull. That is what phrenology is. So I imagine what L.N. Fowler did was he probably felt someone's skull, and he thought, well, that person there has got a particular characteristic. They're good at foresight. Therefore, because it's true in this person, that's going to correlate with the shape of the skull in everyone else. It's like an inductive reasoning thing, isn't it? Because it's true in one case, it's going to be true in all cases. So that's the Phrenology Globe. I don't need to tell you, of course, it is bunk from start to finish. It's utter trash. It was presented as science, and it was utter bunk because it wasn't based on cohort studies. It wasn't deductive reasoning based on a lot of people. So inductive reasoning, you would go from one person to everyone, which is ridiculous. And deductive reasoning, you go from many people to one person. But it just shows you how far up an alley people can get. And the unbelievable thing is this was taken seriously up until the start of the 20th century, and even into the 20th century. This was taken seriously. So we keep it here now. This is a reminder that we need to be evidence-based, that we need to be research-based. Because phrenology is just bunk. People see what they want to see. It's a bit like the canals on Mars. You know, people drew maps of the canals on Mars and they simply do not exist. So when someone says something to you, a good response can be, well, what's your evidence for that? Thank you for watching, as always.